Good morning and welcome to the 13th meeting of the Health and Sport Committee in 2020. I would ask everyone to ensure that their mobile phones. The first item on our agenda is an evidence session on testing for COVID-19, looking both at the strategy so far and at the way forward, with a focus on testing capacity, types of test and the overall testing strategy. I welcome to the committee Jean Freeman, Cabinet Secretary for Health and Sport, who is accompanied by Caroline Lamb, Director for the Test and Protect portfolio of the Scottish Government. Thank you for joining us today. In a moment, I will invite the Cabinet Secretary to make a short opening statement of up to 5 minutes. Unusually, because of the questions and the challenges of managing a virtual meeting, we're going to take the questions in a pre-arranged order. Once the Cabinet Secretary has made her opening remarks, I will start off the questioning and then ask members to ask their questions. I will then invite the Cabinet Secretary to respond and we'll go through the questions in that way. Can I ask everyone please to keep questions and answers succinct, and can I remind you to give broadcasting staff a few seconds to operate your microphones before beginning to ask your question or to provide an answer. And can I now invite the Cabinet Secretary to make a brief opening statement. Cabinet Secretary.
Thank you very much, Convener, and good morning to you and colleagues. And thank you for giving me the opportunity to come along today and have a conversation about testing. Testing is one of the key elements with a critical role in our response to the challenges of COVID-19. As you will know, the symptoms of the virus are the same as the symptoms for many other diseases and infections such as flu, bacterial pneumonia, or even the common cold. And so testing is important for us to be able to identify who has this specific virus. For that reason, to date, we've had 3 priorities for testing: directing our testing capacity effectively to save lives and protect the vulnerable, ensuring that critical staff can return to work as soon as possible if it is safe for them to do so, and monitoring and reporting on the spread and prevalence of the virus. Looking ahead, we will continue to focus on these 3 priority areas, including care home staff and residents with or without COVID-19, as well as children aged 5 and over, while also expanding to do more and more testing of people in the community so that we can identify cases of COVID-19 and through Test and Protect, stop further transmission of the virus. The tests we do have, PCR tests, have proved to be highly accurate, but like so many medical tests, they are not 100% accurate. Recent research in Edinburgh found that the tests have a sensitivity of 91%. That is, that they will identify 91% of clinical cases of COVID-19, but they have a specificity of 100%, which means that they are accurate in detecting only the virus that causes COVID-19 and not other viruses. That is particularly important when you recall my earlier comments about the commonality of some of the symptoms between this virus and other infections. The tests are not perfect, and there are limitations in how useful they are for testing people who don't have symptoms. That's because the PCR test detects RNA from the virus, but can't distinguish between active virus, which causes infection, and fragments of virus, which may still be found long after someone has recovered. The tests also can't tell us if someone is early in incubating the disease, but doesn't yet have high enough levels of virus to be picked up. Testing advances are continuing apace and continue to be pursued in terms of how we take the tests, their accuracy, and what they tell us about the disease itself. Our approach to testing, in common with countries elsewhere in the UK and wider, has developed as our understanding of the virus has improved and as testing capacity has increased. It's worth remembering that we have come a significant distance in a relatively short time frame. For COVID-19, we've had to build our testing capacity from scratch, with the first testing available in Scotland from the 10th of February this year, with a capacity in 2 labs of 350 tests a day. We have now built to a capacity of 15,500 tests a day, with plans to increase this further over the coming weeks and months, to ensure that we have sufficient capacity to meet what we anticipate to be growing demand. All of that said, Convener, I know there are many questions in this area, and it is an area of significant importance. So if you are content, I will stop there and happy now to take questions the members have.
Thank you very much, Cabinet Secretary, for that. And I'll start. I think you talked about the priorities given at the outset about ensuring that capacity was directed effectively, and I think we understand that. There have been criticisms, though, about how far capacity was mobilised and whether more might have been done at the outset. The Deputy Chief Medical Officer for England, Dr. Jenny Harris, told the Commons Committee if we had unlimited capacity, we would have done it differently. So I guess my first question to you is whether that's true in Scotland too. If you had greater capacity, would you have taken a different strategy at the outset? Would you, for example, have stopped the testing and tracing that was done up until the 3rd of April? And would you have taken a different approach had the testing and laboratory capacity been mobilised at the outset?
I think in part that is quite difficult to answer because the testing capacity was what it was, although of course by April it had grown significantly. The use of the testing capacity was in part demand-led, in as much as it was there. We used it from the outset to test individuals in ICU and in respiratory wards, and it was also focused very hard, partly on surveillance, but primarily on key workers. The key worker testing is largely demand-led, in that key workers come forward at that point. And remember, in those early days, there was significant evidence to state that there was no value in testing asymptomatic individuals. That debate has moved on. It's still, as I tried to indicate in my opening remarks, not definitive that there is value in testing asymptomatic individuals, but it has moved. And so we, for example, are now testing asymptomatic care home workers in care homes and giving consideration about health workers in other settings. So the capacity undoubtedly has an impact, but capacity grew relatively quickly. And the clinical advice that we were receiving, for example, was that at the point where community transmission was so significant that contact tracing, test and trace, was no longer viable, we had to shift from the containment phase to the delay phase. And at that point, what you're using testing for, or who you are pushing it towards, if you like, changes. So I think even if we had had 15,500 tests capacity at the outset, I'm not certain, given everything else that was known and the advice that we were receiving, that we would have had a significantly different approach.
When you reflect now on the position we've reached and on the advice and experience, the advice of the World Health Organization, the experience of other countries such as South Korea, where far more laboratories were mobilised at the outset and far more effort was made to test in the community at the outset and to isolate those who might have been infected. Do you reflect on that now and wonder about the efficacy, the correctness of the clinical advice you received 2 months ago, or do you wonder whether a different approach might have put you ahead of the game at an earlier stage?
So I wouldn't feel, Convener, qualified to challenge clinical advice in terms of the content of what clinicians tell me. That I then, along with others in government, have to make a judgment about what I do with that advice. So would I, on reflection now, think that if we had had greater capacity in February, or even at the end of that month, into the very early days of March, would I now, on reflection, think that we might have used testing differently? We may have taken a judgment, notwithstanding the clinical advice, that we wanted to widen testing availability to those who had symptoms, even though we were still at that point engaged in contact tracing. So we might have widened it, we might have looked at different age groups, but again, the age group widening came as a consequence of increasing evidence. So there was debate around in those early days about children, for example. Now the advice clearly is that it is perfectly possible and correct to offer testing to children aged over 5. So the debates have raged back and forward, and it would be wrong of me to say, even with hindsight, I think every decision that we made and all the judgments that I took were, of course, absolutely correct. That would be a foolish position to be in. But I'm not absolutely certain either that in those circumstances, with what I knew, even with more testing capacity, that I would necessarily have taken a different view at that time.
One of the criticisms has been that at the time of the lockdown, there were university laboratory scientists and researchers who were being stood down and sent home and not mobilised to add to your testing capacity. Do you think that was correct at that time? And perhaps more importantly, would you now say that all the potential sources of laboratory testing capacity are now in place and being used to the full?
Well, we have got to 15,500 test capacity by the end of this month, in part by mobilising. Well, we have testing laboratories, testing capacity in every health board across Scotland now, every health board. We have mobilised with our academic partners to add to that capacity. We have also brought in the Scottish Blood Transfusion Service. But as I said at the outset, we need to go beyond that to cope with all the anticipated demand, including our estimates of what might be demanded of us for Test and Protect. And that involves further discussions with our academic partners. It involves consideration about whether or not with them we can have a single larger laboratory that processes more tests. And it will involve some discussion with private providers. But our first port of call is with our academic partners to see whether or not there is more that they can do. There are also, of course, initial discussions underway with some other public agencies, such as Marine Scotland, for example, about whether or not their capacity can in part be used to assist in this. Now, it's not just about the existence of the laboratory, it's the right kit, the right reagents and chemicals, and staff knowing how to do this test. So it's not straightforward, it's not necessarily overly complicated, but it does need all of that to work so that the testing is compatible across all our laboratory sources for testing.
Thanks. My final question for the moment is to refer you back to the Silver Swan exercise to prepare for pandemics, which the report was published a few weeks ago. The report doesn't appear to cover testing. Is it the case that testing was not considered? And if so, is that because the pandemic preparations were wholly focused on the possibility of an influenza pandemic?
I think that's exactly right, Convener. Testing wasn't considered. And that is because it was focused, my understanding is that it was because it was focused on influenza, and it was focused on influenza because internationally all the evidence pointed to the strong likelihood that a pandemic to be faced would be an influenza pandemic. And so testing was not part of that.
Thank you very much. Emma Harper.
Thank you, Convener. Good morning, Cabinet Secretary. Yesterday, I put forward a parliamentary question that Cabinet Secretary you responded to about the test, trace and isolate and support strategy that the Scottish Government is bringing forward. And in the response, it said that it would go live on Thursday, the 28th of May, following successful pilots in NHS Fife Highland and NHS Lanarkshire. I would like to maybe get an additional update, Cabinet Secretary, on progress towards implementing the Test and Protect strategy, if possible, please.
Cabinet Secretary.
Excuse me, of course. So in part, the progress was outlined yesterday by the First Minister at the daily briefing. As of this morning, we now have 1,812 identified contact tracers. The marketing, because this involves a very different message to the public, what we have said to the public so far is that if you have the symptoms, then please isolate at home for 7 days. If you're part of a household, the household should isolate for 14 days. And if your symptoms get worse, you should be contacting NHS 24 or going onto the Inform website. What we're saying from tomorrow is that if you have symptoms, remember those symptoms that we know of, if you have those symptoms, then you should contact us and book a test. And that contact is either through the free phone helpline number or through NHS Inform. A test will be booked. We're telling you at that point when you contact us to isolate for 14 days. And if the test is positive, then we will be back in touch with you to ask who your contacts have been. Who have you been in contact with 2 days prior to you notice the symptoms up to the point when you isolated. So it's a very different ask of the public. It requires significant compliance from the public in order for it to work. It also requires relatively low transmission levels in the community for it to work. So the marketing and the information to the public will started to go out yesterday. It will continue, including door drop information, so that we can make sure that people know exactly what to do and what to do if they are contacted as a contact from the trigger case, if you like. So we will have those 2,000 contact tracers in place and ready to be deployed from tomorrow. We don't anticipate needing them all, but we hold them in a pool, and we will continue to recruit to that number over June. The technology that was tested in those 3 health boards was the scale up of the technology to aid the contact tracers. That technology is at its core what we have used in the health service in Scotland for other infectious diseases like tuberculosis or sexually transmitted diseases. It was scaled up to and focused on COVID. This is, an NHS-led operation, and what that means is that the data is held by NHS, and Scottish Government has no access to that data, held confidentially. So the technology testing in those 3 health boards was to make sure it was now ready to go. It has come back very satisfactorily. Over the month of June, we will add to it, we will put an enhancement to it, which would allow the individual with symptoms to, through a web-based, it's not an app, through the web, to add in their contact details. So in that period, when you are waiting for the test result to come back, you could begin adding in your contact details so that as soon as the result comes back as positive, we're good to go. There'll be some checks with you, of course, that you hadn't missed anybody, but that is the enhancement that would be made to that technology.
Emma.
Thank you, Cabinet Secretary. The contact tracers that have been employed, they're already NHS employees, so I'm assuming that they already have the ability to put into practice a level of competence in contact tracing. You described that the tuberculosis, for instance. So just to clarify that these are folks that are already experienced in contact tracing.
So where we started, as Ms Harper will know, where we started was with our existing health protection teams. Every board has those, and they flex them up or down depending on what they're dealing with. And in those core health protection teams exists a significant degree of expertise and experience. We have added to that. Remember, I said there were 3 routes to reducing the number of contact tracers that we initially estimate we need. The first of those was to bring in other NHS staff. The second was to go to our NHS returners group and identify individuals from there and bring them in. And the third was that public advertising campaign. So as we work through all of those, everyone will be trained to make sure that they are up to speed, know what they've got to do. The contact tracers and the people who will operate the telephony behind this, that place that you go to first, as well as those who are making sure that the NHS Inform website is constantly monitored and maintained to ensure that it can cope with that demand as well as the other demand that is on it. So the training is, there's core training, and then there's obviously specific training depending on the role that you are taking up.
Emma Harper.
Thank you. And the Test and Protect strategy is to find persons who are symptomatic, so it's not part of the strategy, for instance, looking at getting elective surgery back online, or getting cancer, I guess cancer screening services back online. Just to clarify that Test and Protect is to find people who are symptomatic.
Yeah.
Cabinet Secretary.
Yes, Test and Protect is a strategy you use when transmission levels in the community are low, as they are coming down now in Scotland. It's a central part of releasing any of the restrictions of lockdown. Remember, we brought transmission levels down because of lockdown and because of the huge public compliance with that, with all the sacrifices that involved. Transmission levels have been brought down. As we release any of those measures, you would sensibly expect transmission levels to increase. Test and Protect is there to quickly identify where that is, track it down, contain it, and stop it going any further. So it is. It was described, I think, by Ken MacDonald on Good Morning Scotland as hunting down the virus, and that's a reasonable explanation. It centrally requires the public to comply with this and therefore to trust that their data is held confidentially. And that is why it is an NHS-led exercise, and why it is really important that people understand that data is held in the same degree of protection and confidentiality as your medical records are held. Government ministers cannot access that, and it will be held for this purpose only, and then no longer held.
Emma Harper.
Just a final question, Convener, and thank you again, Cabinet Secretary. What kind of support will the Scottish Government be implementing then to enable people to isolate effectively?
Cabinet Secretary.
So part of the information that we will put out in an iterative basis to people across Scotland, including to every household, is telling them, if you're asked to isolate, what are we asking you to do? Of course, what we're asking you to do is not to leave home at all for any reason, and therefore to think a little bit in advance, in case that is an ask of you, about who do you have, if anyone, friends or family, who can help you to provide food or collect medicines, or in other ways help you for those 7 or 14 days, depending on what you're being asked to do. But also, we are standing up in this direction the significant local operation that public health partnerships have put in place to support that group of people that we have asked to shield over the last number of weeks. So that operation will expand its locus, if you like, to also then provide support to individuals who are asked to isolate. And that could include individuals in circumstances where it's not possible to isolate in your household, You don't have that extra bedroom where you could go off and sleep and so on. Or there may be other reasons why that's not possible. So each local public health partnership has worked up its plans about how it will be able to offer you accommodation and support in those circumstances for that period of time.
Thank you very much. Brian Whittle.
Thank you, Kabira. Good morning, Cabinet Secretary. Can I ask initially how the Cabinet Secretary, how important the contact tracing app will be to tackling the ongoing pandemic?
Cabinet Secretary.
So, good morning, Mr. Whittle. I'm not sure when you say app what exactly you're meaning, but let me tell you about the Scottish digital technology we will use here in Scotland. And it is a piece of digital kit, as I said to Ms. Harper, that has been developed from what we have used in the past for infectious diseases, for contact tracing. It's there initially. Its current format from tomorrow assists the contact tracers to do their job. And then over the course of the month of June, we will add an enhancement to it, which would allow you, if you were the trigger case, if you had symptoms and you'd phoned or gone on to NHS Inform to book a test, you would be able, through the web, not an app, through the web, to begin to add in your contacts that you can remember you were dealing with in the 2 days or so before the symptoms appeared, right up until the date when you make that phone call and you begin isolating. The app you may be referring to is the UK government's Proximity app that was trialled in the Isle of Wight. We remain interested in the development of that app. The UK government, my understanding, but my colleague Ms Lamb may be able to give a bit more detail. My understanding is that the UK government are reviewing that app. We have a number of questions that we need to have resolved around if we did use it or offer it for use in Scotland. Can we make sure that the data that comes from it feeds into our system so we get the KI number and the identifier, and therefore we can find you and whoever the app pings as your contacts. So there's a number of questions still to resolve, but my understanding at the minute is the UK government is currently reviewing the result of its trial in the Isle of Wight to determine what more it might do with it. So at the moment, it's not yet available for us to make a decision about whether or not we would find it an enhancement to what we are doing.
Brian Whittle.
Secretary, can I, just for clarification here, just so I understand exactly what's on offer here from the Scottish Government. So you have a digital platform that will rely on the individual who is symptomatic inputting into that digital platform and talk about the people that they have been in contact with. And as it currently stands, there's not a Scottish app or contact trace Scottish application that will enhance that ability. Am I hearing you correctly, Cabinet Secretary?
Cabinet Secretary.
So two things. First of all, it doesn't rely on the individual putting their contacts into it. Remember, we've got those contact tracers, but it does give you as that individual the opportunity to help us by putting those in without waiting for a contact tracer to get in touch with you. So while you're waiting for your result to come back, you could begin doing that. It's an enhancement. It's not central to the work. The real work is done by those, if you like, boots on the ground, the contact tracers who are in touch with you and taking you through a series of very important questions about who you've been in touch with and where you were and so on. And from that, they make decisions, not just about the individual that you might have been in contact with. Bear in mind the definition, less than 2 meters, longer than 15 minutes, not just that individual, but where you were and whether others in the vicinity should begin to be contacted too. So it doesn't rely on the individual. In terms of are we developing a proximity app in Scotland? No, we're not. If the UK government's proximity app, which would work most effectively if it was UK-wide, is one that the UK government decides on its review that it wants to go ahead with, and we can sort out those information flows, then it would assist across the UK, but that's not yet determined.
Brian Whittle.
Again, if I become symptomatic, the likelihood is I wouldn't get a test. But if I become symptomatic, it would still rely on me to log into that digital platform and relay my symptoms into that, so that contact tracer would then come out to me. Is that the sort of process that we were looking at just now?
Cabinet Secretary.
No, it's not. I'm not sure why you think you wouldn't get a test. If you have symptoms, then you do one of two things. You use the free phone number, or you go onto the NHS Inform website. Whichever of those you use will book a test for you. As soon as that test result comes back, we will know what the test result is, or our contact tracers, our operation will know what the result is. If that test result has Brian Whittle positive, then our contact tracers will be in contact with you to ask you about all the contacts you've had and take you through that whole exercise. And they will be using the digital tool to speed up the process for them. It's about speeding up. It's an aid to their work. The only additional thing that will be available at some point over the month of June is that while you wait for that test result to come through, you could aid the process by beginning to put into, using the digital app, begin to put in your contacts yourself. It's about speeding up the process, because in all of this, speed is really important. The quicker we get the virus nailed down, contacts identified, nailed down, then we're breaking those transmission chains.
Thank you very much.
I'm sorry to labour this. Yes, I'm sorry, Convener. It's just to labour this point. It still relies on me reporting that I am symptomatic, and then having to have somebody come out and test me before that goes onto the digital platform. There's still an onus on the individual and that's where I don't understand why we're not looking at a proximity app here to aid that.
Briefly, Cabinet Secretary.
Yes, it does rely on the individual. I think I said that almost in the first 3 minutes of speaking this morning. It relies absolutely on the individual, just as obeying the lockdown restrictions relied on the individuals. If individuals had not been convinced that obeying the significant restrictions on daily living that they have put up with for a number of weeks, if they had not done that, then lockdown wouldn't have worked. So this, of course, relies on the individual. The difficulty with the proximity app, as I understand it so far, and why the UK government is looking at it again, is that its sensitivity. There is no value in a proximity app that pings with everyone that I walk past, because I've walked past them. I've not been within 2 meters of them. I've not been in face-to-face contact with them for longer than 15 minutes. So it's not specific enough to really aid contact tracing. But that doesn't mean it can't be. And that is what the UK government is looking at. And what we have said all along is if we can get to a point where it has that clarity, that is that specific, and doesn't send contact tracers off trying to trace contacts that are not relevant to the case definition, but can be used in that clear, focused way, and we get the information channels right, so that if it pings it's Brian Whittle, then we know that, and we know your CAI number, and we can get to you and all of that, then that will be significant enhancement to all the work, but it is not there yet. And the Isle of Wight trial was of value, I'm sure, to UK government, but again, didn't yet have sufficient numbers of people downloading it. The other point I'll make is that that app, when it overcomes those glitches, and if it gets that level of take-up from the public, it needs to have between 60 and 80%, there's a debate about what level, for it to be effective, still will not necessarily reach individuals who will not download the app. So the central part of the approach, which is we rely on you to tell us you've got symptoms and book a test, remains, because not everyone will want to download an app on their phone.
Thank you. Cabinet Secretary, can I ask a very brief supplementary to that? Straightforward, I guess, yes or no. If a contact is identified and traced but does not have symptoms, does that person then get tested, or are they simply left in isolation? Cabinet Secretary.
So as a contact, so let's imagine that I'm the trigger case convener and you're one of my contacts, because we were closer than 2 meters and for more than 15 minutes. You will be contacted and told that you are a contact of a trigger case. You will not be told who the trigger case is. This bit's really important. You won't be told that. And you will be asked to isolate for 14 days. If my test result comes back negative, you'll be contacted and said you're fine. You don't need to continue isolating. You won't be tested because at that point you don't have symptoms. And we're back to this point about testing asymptomatic people and whether there is value to that. So you won't be tested unless you yourself in those 14 days develop symptoms, in which case we'd be off again and looking at your contacts. The other important thing to say here is not only will you not know that I'm the trigger case, but if Mr. Whittle, for example, was another of my contacts, he won't know that you're a contact either. This is all kept very siloed, if you like. This is good siloing, very siloed in terms of who knows what. The only person that knows the whole story is the contact tracer.
Thank you very much. David Torrance.
Thank you, Convener, and good morning, Cabinet Secretary. In order to test, trace and isolate to work effectively, test results need to be delivered quickly. Can the Cabinet Secretary confirm what the average turnaround is for testing currently and what it needs to be in order to underpin effective test, trace and isolate?
Cabinet Secretary.
So for the current turnaround, remember we have two testing systems, if you like, two lab systems in Scotland currently undertaking tests. We have the NHS lab system, which is all those NHS labs in territorial boards, but also the academic partners and others that I mentioned at the start. And we have the Lighthouse lab, which is where tests from the regional testing centres go. In order to confirm the times currently in those, I'm going to ask Carolyn if she would give you that information. But in terms of what we're aiming for, so our Chief Medical Officer's office tells us that it needs to be within 48 hours to do the whole thing. What we're aiming for is a 24-hour turnaround, because again, we're back to speed being of the essence. So that's our aim, and that is what we don't control what the Lighthouse Lab does, but we can ask them to get to that point. That is what we're aiming for in all our labs with consistency. Some are coming in under at different times, but we need the consistency across them all.
Caroline Lamb.
Thank you very much. Yes, just to confirm that within our NHS, our Scottish controlled labs, we are now consistently achieving a within 24-hour turnaround. In relation to the lighthouse capacity, which clearly for us is largely Glasgow, the most recent figures from the UK government are that they're now achieving 89% turnaround within 48 hours with a strong commitment to improve that. The area where we do have most difficulty is in respect to the Milton Keynes Lighthouse, which is where the home testing kits currently go. And we haven't got yet good data from the UK government about turnaround times there, and that is something that we're raising with them.
Thank you very much. David Torrance.
Cabinet Secretary, there is now increasing evidence to suggest that asymptomatic and pre-symptomatic people may be infectious. What proportion of cases does the Scottish Government assume are asymptomatic? And finally, are there any plans to routinely test the population or certain people even when they have no symptoms, like key workers, care home residents?
Cabinet Secretary.
So if you give me a moment, I think probably in terms of answering your first question, I think that is probably where we are on surveillance testing. I think that would answer your question, Mr. Torrance, and if you give me just a moment till I get to that. So the current surveillance testing programme is, the most recent results is that the assessment of proportion of individuals in the community who have the virus. This is the swab testing programme that we talked about before. With a 95% confidence interval level, the estimate is that the true figure currently, this changes over time, is between 2.9 and 7.5%. So that's individuals that are not symptomatic necessarily, but we are through the surveillance testing spotting them, if you like. And that surveillance testing will continue. It doesn't stop. It needs to keep going because it helps us to understand the level of the presence of the virus in the community, alongside what we do with Test and Protect. My apologies, I've forgotten your second part of your question. Could you just remind me?
David Torrance.
Are there any plans to routinely test the population or certain people even when they have no symptoms, like key workers, care home residents?
Yeah.
Cabinet Secretary.
So you recall what I said at the start about asymptomatic individuals, the current debate and the accuracy of the test in those situations. You'll know that we have introduced testing for care home workers in care homes where there is no active case, and that is a precautionary measure to try and prevent the introduction of the virus as far as we can into that care home. But what that requires is that it is testing that you have to do every 7 days. You have to keep repeating it because all the test does is tell you whether or not you have the virus at the point when the test is taken. So you could test 20 care home workers, they're all negative. You can't then assume that everything is fine. You need to go back in 7 days and test them again, and you need to keep doing that. So there is some discussion. I have asked the Chief Medical Officer's office for advice on the testing of health workers in healthcare and also in specific settings as to what their view of that is for us. There is certainly, in terms of our planning assumption for testing capacity, a planning assumption that would allow us to cope with that. But I need the Chief Medical Officer's office and his scientific advisory group, chaired by Professor Morris, I need their view on whether or not there is a value in this. And if there is a value, is it general or is it in specific settings? And that's particularly relevant as we do the work to restart areas of the health service, as you mentioned yourself, Mr. Torrance. Is it particular that we would do it in particular parts of the healthcare setting in order to give us additional confidence about restarting elective work or any other area of health?
Thank you very much. Miles Briggs.
Thank you, Convener, and good morning, Cabinet Secretary. The First Minister has accepted that the care home transfer policy had likely contributed to resident death toll that we've seen in care homes. Now, given what we knew was happening in care homes in Italy and Spain, why were new care home residents not tested on discharge from hospital?
Cabinet Secretary.
So there's two things I would say about that. The first of all is that testing in and of itself is not the only precautionary measure that you should take. And as I'm sure Mr. Briggs recalls, in 13th of March, we issued guidance to care homes that advised them about measures that we needed them to take in order to reduce the risk of transmission inside the care home. And that included ending or significantly reducing at that point levels of communal activity. Residents should eat in their own rooms. The infection prevention and control measures should be ensured, that PPE should be used, and at that point that visiting with some exceptions should be stopped. All of those measures contribute alongside testing, but all of those measures, and I'd argue that infection prevention and control, quality infection prevention and control, which includes the right use of PPE, is central to preventing the transmission of the virus. Now, you'll know that we have subsequently introduced very specific requirements on testing in advance of admission. That has come as a consequence of our increasing knowledge of the virus. As I've said before, I am sure that if I look back at decisions that were taken by me individually or as part of government at various points along this journey from the start of this year right through to date, if I had the information or the knowledge or the experience that I have now, then I may have made different decisions. But I didn't have hindsight then, Mr. Briggs. I have it now. And what I need to do now is make sure that as I acquire that increased knowledge and understanding and changing advice and recognise what difference that might make to what we're doing, then I adapt what we're doing to incorporate that.
Miles Briggs.
So given what you've just said there, Cabinet Secretary, is it fair to say then that the priority was around freeing up NHS capacity, not necessarily putting in place these safeguards which should have been in place for care home residents?
Cabinet Secretary.
Well, you know, it's really interesting because one of the things I've done most recently is go back and look at the statements I made almost on a weekly basis in March to Parliament. And the first statement I made was on the 3rd of March, where I gave at that point the numbers that had come from SAGE modelling on the estimated worst case scenario, which is what we were all across the UK, every nation of the UK, working on. And that was an estimate, I'm sure you recall it, that said that 80% of the population would be infected by the virus. 4% of that 80% would require hospitalisation, and that included ICU. And that therefore meant that in order to prepare for that, we had to significantly scale up the health services capacity to cope with that volume of cases, because we did not want, having looked at the experience elsewhere, to find ourselves in a situation where we were overwhelmed by cases, because that would mean that those individuals could not get the clinical care and treatment that they needed. And my recollection of all of that debate then, and again on the 10th of March and again on the 17th of March, when I set out what that means about doubling initially our ICU beds, then tripling, and now we're working towards quadrupling those, creating that 3,000 bed capacity inside our bed numbers. It involved stopping procedures like elective work and other areas of work, and improving on our delayed discharge. Those individuals in our hospitals who are clinically fit to be discharged but are delayed beyond their discharge date because care packages are not available for them in the community or in care homes. And my recollection is that all of us felt that that was where our focus had to be. We did not ignore care homes. We were conscious of that. 13th of March, that first piece of guidance came out that was approved by the CMO and Health Protection Scotland and others. And we went from there. Now, where we are now, looking back there, I don't think I would necessarily be the only one of us who thinks if I knew now if I knew then what I knew now, maybe we might have taken different views or additional views in addition to the ones we did then. But that's where we were a short time ago, and that was the approach we took. And I think it was at that point a collective approach. It was certainly a collective approach across the 4 nations of the United Kingdom.
Thank you very much. And I remind members that we will have another session on care homes with the Cabinet Secretary in the near future. Can I move on now to David Stewart?
Thank you, Convener. Good morning, Cabinet Secretary, and good morning to Caroline. I move on to talk about antibody testing, which can tell us various degrees of accuracy when someone has previously been infected with the virus. The Cabinet Secretary will be aware, but earlier this month, health officials in England made a breakthrough with the Swiss developers, Roche, who developed a new antibody test described by health officials in England as a positive development. When will we see mass antibody testing here? And does the Cabinet Secretary have specific procurement plans, bearing in mind that the test has been approved both in the EU and in the US?
Cabinet Secretary.
So there's quite a lot of work going on different kinds of antibody tests. There's the serology, the blood antibody test that is testing that is underway here in Scotland. It started on the 6th of May and it is being led by Health Protection Scotland, involving samples taken from 6 mainland boards, but is now also using samples taken from smaller NHS boards. So this is taking a sample of the blood that is taken for other reasons. So it's pseudo-anonymised, I think is how they describe it. And what that is showing us at this point, but remember, it's still early days, that 95% confidence level indicates that the proportion of the population that has antibodies is between 3.4 and 13.6%. So it's a wide range, and the more they do it, the more they will begin to narrow that down. It will always be in a range. The other issue around antibodies is identifying if people have them, but then knowing how long they stay with you. So if you think back to another coronavirus, which is flu, all of us, I'm sure most of us at some point in our lives have had the flu. That doesn't protect us from never getting the flu again because the strains of it change. So antibody testing is important, but again, it's not a silver bullet because there's much more to do to understand whether having the antibodies protects you against this virus, and even if it does, for how long is that protection in place? In terms of the particular announcement from the UK government about antibody testing to health and social care staff, health and social care staff and patients in England, and their deal with the Roche Diagnostics and Abbott laboratories, then we are engaged with that. You'll have seen that there is some testing going on involving healthcare staff in Scotland on antibody testing. I think you might have seen some of the media reports on that. The thing about all of this testing is that you need to let it all happen to finally settle on the antibody test that gives you the greatest certainty on its results, certainty of an equivalence to the certainty we have currently on the effectiveness of the PCR test. And then you work plans to use that and introduce it. So whilst with our Chief Scientific Officer, Professor Crossman, all of that work is underway, as well as work that relates to, contributes to vaccine development and so on. Whilst all of that is underway, we have an eye to it and an eye to what we might need to do in order to procure it and then put it into our own programmes. And we have, as you know, an extensive vaccine programme in Scotland, and this would become part of that. So we would build on that. But at the moment, that is where we are. We have a very close eye to it. We're watching its development, and we're ready to use it, to plan to use it when one of them comes through with less uncertainty around it than they all currently have at the moment.
Thank you. Can I make my final question, Cabinet Secretary? Can I ask you a bigger picture issue? Would first of all you agree that antibody testing, to use a kind of military analogy, is really a second front? We've got antigen on one side and antibody on the other side, and that if we looked at the bigger picture of what's happening across Europe, I noticed that Germany had over 61,000 tests of antibody tests last week, and Spain had around the same. How many antibody tests are you carrying out in Scotland? And in the future, bearing in mind that Roche argue that their test following the Porton Down facility evaluation is 100% correct in terms of looking at people who've had infections, would you see a development of frontline key staff like NHS and care and police effectively having immunity certificates in the long term? Now, I do appreciate there's some controversy around this, but I'm looking at the long term where antibody testing can be a crucial tool to try and get us out of this deadly pandemic.
Cabinet Secretary.
So my general answer to that, Mr. Stewart, would be I would not rule that out. That doesn't mean I'm ruling it in, but I wouldn't rule it out. And the reason for that is partly because there is a degree of controversy, genuine controversy. There's some ethical issues to work your way through here on this, but also my point about having immunity. For how long do you have immunity? We don't know yet whether COVID-19 is going to perform the way the coronavirus that gives us the flu performs. And that is that new strains emerge. And so the fact that you had flu last winter does not protect you from getting flu this winter. And remember, flu is a coronavirus. Common cold is a coronavirus. So the degree to which any antibodies that you have and the level to which you have them protects you from acquiring COVID-19, and for how A, does it, and B, for how long does it protect you, are also really important and questions to ask, answers to which will come from all this research and all this work that is underway globally, includes Scotland and the rest of the UK, but globally. And so that's why I'm not ruling it in, I'm not ruling it out. I think there's a degree to which we can be confident about the efficacy and the longevity of those kind of tests in terms of what they tell you, and there are those ethical questions. So I wouldn't dismiss it, but we need some answers to some of those important issues.
Thank you very much. George Adam.
Thank you, Convener. Good morning, Cabinet Secretary. I would like to ask about travel. Now, my question is probably taken on a different perspective over the past couple of days, because as part of the success of the lockdown and how we protect our communities is the discipline that the public have shown over travel restrictions. But Cabinet Secretary, do you share my disgust and that of many of my constituents when we hear of a senior UK government figure taking a 250-mile jolly with his family. Let's not even talk about his eye testing situation of a 30-minute drive when Dominic Cummings becomes the real-life Mr. Magoo. Do you think it's disgusting that someone in a senior position like that would abuse his position likewise?
Cabinet Secretary.
Well, I think all of us who are in positions of influence, whether that is you, Mr. Adam, as an MSP, and your colleague MSPs, I as an MSP, but also as a Cabinet Secretary, not just influence, but decision making, I think all of us have an absolute responsibility to exemplify the behaviour and the restrictions that we are asking others to do. Because these are serious restrictions that we have asked people to comply with. And I know that you will have, as I do, constituent experiences where there have been genuine heartbreaking decisions that they have taken about not being with people they love, and genuine worries that they have about if they are ill, how would they look after those who are dependent on them. And so my view is that we have, all of us collectively, in the positions that we occupy, a very serious responsibility to abide by what we ask others to do and to model that behaviour. But I also have, as I said when asked about this before, I have a real concern that if the message that goes out is that the restrictions, what we ask you to do, is somehow negotiable or on a take it or leave it basis, then what we will see, if, for example, Mr. Whittle touched on this, if, for example, the public do not do as we ask them, which is if you have symptoms of the virus, you must now contact us and book a test and isolate for 7 days and tell us about your contacts. That's a big ask of the public. If they don't do that, then what will happen is, as we ease lockdown measures, the virus incidence in the community will rise. There is a serious risk of a second wave, and all the gains of the past 3 months are lost. So it's a serious matter. What happens to an individual in a particular circumstance in this instance is not for me, but it is a serious matter to be taken very seriously indeed.
Thank you, Cabinet Secretary. I've had many constituents who have obviously become quite upset regarding this situation, but what would you say to them, particularly with regards to they have stayed by the rules, they've done everything correctly, but now they're saying, can I drive to a holiday home? Can I go and see my dying relatives in the hospital? Can I do things differently because of the message that's been sent out by this issue?
Cabinet Secretary.
What I'd say to individuals in that circumstance is, please don't. You have achieved so much by what you have done, and I do not underestimate what that has cost you for 1 second. But what you are doing isn't just about protecting yourself and your family, it's about protecting your neighbour and your neighbour's neighbour, and what they do protects you. This is an approach that requires us to think not just about ourselves, but to think about others. Professor Riker from St Andrews University, who is a member of our CMO's advisory group, I think put it really well in that what he said was, what we are doing is we're asking people to think about the we, not the I. And that really matters. If we are not successful, continuing to be successful in that, and I am hugely grateful for the percentage of the Scottish population who have been doing this and still are doing it and still intend to do it. If we're not successful with that, then we are not going to be able to control the transmission of this virus. And that will have serious consequences for people's lives. It's not hyperbole, it's not dramatic, it is simply a statement of the facts.
George,
And Finally, Cabinet Secretary, different countries, it's about inward travel now, and different countries have taken different approaches with regards to inward travel during the pandemic. New Zealand banned inward flights from China early on. Can I ask you, Cabinet Secretary, what powers do the Scottish Government have in relation to inward travel? And will there be any testing of people arriving, and what form could that take? As you've already explained, there has been during this pandemic some question over various methods of testing.
Cabinet Secretary.
So we don't have the powers to control borders. That is for the UK government to determine and to decide. So the border force, for example, is not a force under the locus or the remit of the Scottish Government. The UK Government have now said that they intend to impose restrictions on travellers coming into the UK. We are working with them to understand the detail of those restrictions and to ensure that where there is then a requirement on us for our devolved powers, that we are prepared and ready to deliver on that requirement. But the nature of the restrictions that are imposed is for the UK government to decide. And the work is going on to understand and to put our views into that four-nation discussion, because it does affect all the nations of the United Kingdom, to put our views into that and to see if we can reach an agreement about what those restrictions should be and what should be asked of and required of inward travellers, remembering too that some will be citizens who are returning home. So we need to work out all of that detail. The work is going on because, again, as with everything else in this pandemic, pace is really important, and we will be able to provide more details about what we are doing, and the UK government will provide details about what it requires from inward travellers, I would imagine, in the very near future.
Before I turn to Sandra White, I have a brief supplementary on travel from Emma Harper.
Thank you. Thanks, Convener, for taking my supplementary. Last week at Rural Committee, Maureen Watt asked Michael Matheson about the consultation that had taken place with the Scottish Government about travel, and the CabSec, Michael, responded saying there was no formal consultation. So I'm pleased to hear there's now working together from the UK Government around travel. But one of the issues that CabSec Michael Matheson raised was that there would be issues of quarantining people who came in through Heathrow and then had to travel on to Aberdeen or Glasgow or Edinburgh. So is that part of the discussion? Because that's really important that the Scottish Government are included in these kind of forward planning. And, you know, for me, I've got a border at Gretna that's 30 miles along the road, but also a border of Cairnryan, which is where the Europeans from Ireland south and then coming through. So there's some real issues where the Scottish Government needs to be included in these discussions. I would just appreciate your thoughts on that.
Cabinet Secretary, briefly, please.
So I wouldn't. My opinion would be that we have not been overly involved in those discussions as much as we would want to be. To pick up on some of the issues that Ms. Harper raises, you know, it's not just about Glasgow Airport and Edinburgh Airport. It's also about what happens at Heathrow or Manchester or Newcastle, and then of course there are our marine ports as well. So there has been engagement with officials. I know that the First Minister, along with other First Ministers, had at least one call with Michael Gove. I'm not aware if there were others. There may have been, but there was one call that I'm aware of where some of the issues that I have rehearsed were raised, and the commitment that discussion would continue. And that is, as far as I know, where we are at this point, although that doesn't mean that I know everything about where we are at this point.
Thank you very much. Sandra White.
Thank you very much, Convener, and good morning, Cabinet Secretary. Before I go on to my question, if I could just add to George Adams' question, I think people really need to be aware that the so-called guidelines that Dominic Cummings has quoted was put in late by the NSPCC to protect children and mothers who are fleeing domestic violence. And I think that's a strong point. That anybody would hide behind that is absolutely unforgivable. I just wanted to add that in there. My questions, Cabinet Secretary, are about quality and location of testing, if I may. And we had some evidence that had been given to us, although I did look up the website and it mentioned about full training and PPE provided and lab experience. But what we've been given in the papers from evidence has said that unregulated volunteers were carrying out swab tests and children were being asked to take their own swabs. Could you please clarify that point for me, please, or for the committee?
Cabinet Secretary.
So I'm not entirely sure. I certainly don't know where that evidence came from. In terms of the testing that is controlled by NHS Scotland, we don't use volunteers and we don't use children. That testing is done by properly qualified individuals to take swabs and undertake tests. Of course, individuals might be asked to take their own test. That's the home test kit that is currently available in a limited capacity and not available in every part of Scotland. This is the kit that is delivered to your home with instructions on how to use the swab, how to take the sample. I have to say, taking this particular test, the taking of the sample is intrusive, and you do have to stick that swab quite far up your nose. And if you're doing it to yourself, you may be tempted to stop at the point where it begins to be a wee bit uncomfortable, and that's, I'm afraid, not far enough. You need to keep going. So there are some concerns around individuals doing their own. My understanding of the UK government's regional test centres is that on occasion, if not in every instance, the individual who drives up to the test centre at their appointed time is asked to take their own swab under guidance. So there's guidance there for them. So you're not on your own in your own house, but those centres, and that's how that is undertaken. And that would also include the mobile units, because they are staffed by the armed forces, where we intend to use the mobile units, which is in our care home setting. They will be supplemented by appropriate clinical staff from the local NHS who will be doing the swab, who will be applying the swab to get the sample for the test.
Thank you, Cabinet Secretary, because I had checked that out on the website that said that full training and PPE was applied and lab experience was there also. Just to further on in that particular one, because you mentioned about the driving centres, which I'm led to understand it's a UK-wide one, and so I just wondered, has there been, we know there's been training in Scotland because it's on the website, but has there been training in quality assurance carried out in these testing centres or any of the testing centres?
So we have, so you're absolutely right, Ms White, it is part of the UK government programme, and we have a number of drive-through testing centre, regional testing centres now, with the latest one at Prestwick due to open this week. What that one opening at Prestwick does is it frees up one of the mobile units for us to deploy elsewhere, so that will happen. In terms of quality assurance, and so on. And I should say, in response to your earlier question, of course, PPE is absolutely critical in these situations, and staff should be properly equipped with PPE who are applying the swabs to get the sample. In terms of quality assurance and so on of those centres, I think probably Carolyn is best placed to answer exactly what is put in place there to ensure that.
Thank you.
Carolyn.
Thank you very much, Cabinet Secretary. Yes, so we've established a clinical assurance group in Scotland to oversee the UK testing programme. So that's the group that would identify any issues and seek to resolve those, working with UK government clinical colleagues. It's also probably worth pointing out that we have now got a draft of a memorandum of understanding between the UK government and Scottish government, which we're considering details of at the moment and just working through to make sure that we're entirely happy with all the arrangements that are set out in that.
Thank you very much. Thank you very much, Caroline. That's very useful. And perhaps when this evidence is known, the memorandum of understanding, will that be made available to the committee in that respect, or would that? I see the CABSEC nodding their head, so I'll take that as a yes. And this is my last part of the question. I was really very interested in some of the evidence you gave, Cabinet Secretary, in regards to testing. The Scottish Government at the moment is 24 hours. The UK Government testing is 48 hours, which appears to be the top level. Can't go over 48 hours. And the one I was quite intrigued was home testing kits go to Milton Keynes lab, and that has raised a lot of concerns in regard to time scale. So I wonder if perhaps you could clarify that particular point for me. And the very last question onto that, excuse me, would be, we've got mobile units, etc., but are we perhaps looking at more testing in the community, like pharmacies and things like that as well? Thank you.
And perhaps you could verbalise your agreement that the memorandum of understanding will be provided to the committee.
I'm very happy to, Convener. When the memorandum of understanding is finalised and agreed, I will of course send it to you to share with the committee. On the Milton Keynes issue, I will come back and ask Carolyn to just talk you through exactly what the issue is there, including making sure that the home tests that are undertaken in Scotland, that the data from that feeds back into our system, because I think that's quite important. The other test I should mention that is being trialled, if you like, is the saliva test. Members may have seen some media coverage of that, most recently down in a part of England where it is being trialled. It's a much quicker test, but it is also underway in Lothian, started a week ago, 19th of May, to compare saliva and nasal swab samples to determine whether the saliva test, which is a less invasive, obviously, and quicker test, whether it is comparable in its efficacy to the nasal swab test. So that is underway in Lothian. In terms of where people can get tested, I am very conscious that simply saying to people to go to the drive-through centres is very limiting for many individuals. Not everyone has a car. I think it's over 20% of people, I don't know the exact number, but over 20% of people in Scotland do not have their own vehicle. People may be unwell, and so driving with any degree of impairment is never advised, and there can be some distance to go to these regional testing centres. So we are actively looking at what else we may do, including the potential use, none of this is finalised, the potential use of our existing COVID assessment centres. You remember we set up a community-based COVID pathway in order to ensure that GPs could continue to treat their patients who did not have COVID symptoms but had other healthcare needs. Those COVID assessment centres and hubs remain and will continue, whether or not that's possible, as well as looking at the options we might have for other community high street based testing areas. Again, making sure though that individuals who have symptoms of COVID are not asked to travel very far, and that others who may be using those premises too are protected from transmission of the virus. So you need to be very careful with this and look at what our options are for taking a test to an individual's home, where for a number of reasons, they may be a single parent with children, they can't leave the house, don't have anyone to look after those children, they may be physically impaired or elderly, or there may be a number of reasons why someone can't leave their home easily at all. And the final area we're looking at is providing transport for individuals to testing areas in order to ensure that they can be tested as quickly as possible. The overall objective here is to make this as simple and straightforward and easy to do for people as we possibly can, because we know we're asking a lot of them, and therefore let's remove as many barriers and obstacles in their way to doing what we want them to do, which is get a test and give us your contacts as we possibly can.
Thank you very much. Alec Cole-Hamilton.
Thank you very much, Convener. Good morning, Cabinet Secretary. Funnily enough, I've a range of questions that spin out of answers you've given previously. The first is actually related to the last sentence you said there. Concerns that I've had expressed to me by constituents, particularly key workers who until now were the only people that could go to the testing centre at Edinburgh Airport, was about actually getting there. And you said you were looking to institute transport, but it would strike me that for this the scheme to work, to get everyone tested who needs to be tested safely, we need to have that in place now. What do you envisage that looking like? Is that going to be a specialised taxi firms or patient transport, or what is it?
Cabinet Secretary.
Well, there's a number of options, and when I say we are looking at these things, please don't take that as meaning that we're going to be looking at it for a while before we decide anything. What it actually means is that final decisions have not been made at this time on a Wednesday morning. They may be made by this time tomorrow morning, they may not be, but we understand the need to move at pace with all of this and get these final bits of the process quickly decided upon and put in place. But you'll recall, I think, that we had a very kind offer from Arnold Clark to make available a number of their vehicles, that offer, and that has been taken up and used, a number of their vehicles, and that offer remains. We have a number of black cabs, which of course have the protection between the passenger and the driver as standard in a black cab. And black cabs not being used very much at the moment because of the nature of the restrictions that are in place, and in the immediate period not likely to be used significantly more. So again, discussions are underway there, as well as with our ambulance service about whether or not there is anything they can do, bearing in mind there though that we are looking to restart parts of our health service where patient transport is required. So there's a limitation on what we should be asking of our ambulance service. But much more importantly than that, or as importantly as that, is how many other locations can we safely offer the testing that is close to home, that is a short walk away, as well as what is our capacity to offer testing at home so that the test comes to you. And all of that work is well underway. I expect that decisions on all of those areas will be able to be made in the very near future. And as we do that, those will inform the information we put to the public, the marketing campaign and so on, the offers that are made to you when you phone or are in touch to book that test, all the different ways by which that can be done and delivered to you will be added to iteratively as we bring them on stream, and we will of course make sure that the committee knows what those are.
Alex Cole-Hamilton.
Thank you. Can I move on to testing of people with additional support needs or those with dementia? The test, I have had 2 tests and they are brutal and they are not comfortable at all. And if for this scheme to work, then anybody who exhibits symptoms who may have been out on an outing or to the shops or anything like that will need to be tested to have that established that they have COVID before the contact tracers can do that. Will there be specific provision made for testing people with additional support needs or those with dementia who might be very, very distressed by the physicality of the test we're asking them to undertake?
Cabinet Secretary.
This is a really important question, I think, and it is, of course, an issue currently in our care homes. And there may well be occasions where it is not possible to administer the test because the distress required from the individual, the distress of the individual is too great. And in those instances, then we need to find other ways to prevent transmission. So that may be presuming that the person is positive and beginning to trace their contacts regardless. We don't have a test, we don't know for sure that they're positive, but getting the test is way too distressing for that individual, so we are not going to do that. But we will try and identify all the places they've been and seek out their contacts on that basis. So in the absence of a positive case, a positive test. If they were a contact, then we would be requiring that they are isolated at home or wherever they are for the 14 days along with everyone else, bearing in mind that that in itself is not straightforward in those instances. And we need to ensure that, as well as the kind of support that I talked about earlier, there is a version of the support for our shielding programme, we need to put into those situations good quality clinical support. And our local health protection teams who are running all of this operation for the health service, those health service protection teams are able to access that and make sure that that can happen too.
Final question from Alex Cole-Hamilton.
Thank you, Convener. And final question is about contact tracing. What is the depth of the information or the dive that contact tracers will do into people's movement? So do you envisage a time when they may need to look at store CCTV footage or transaction histories, things like that? If they fear a major outbreak may be on the way, would they dig that deep?
Cabinet Secretary.
So, by and large, they decide this on the basis of what an individual tells them about their contacts. And remember, this is an iterative discussion with an individual. So it is, let's imagine I was being contact traced about what I had done so far this morning, then I would describe leaving home. They'd want to know who was at home, how did you get from Glasgow to Edinburgh? Who were you with? Did you stop at any point? Did you speak to anybody? Did you call in at a service station, pick up a sandwich, whatever? What did you do? When you arrived, did you stop at any point on that journey? When you arrived here in St Andrew's House, what did you do? Did you stop and speak to anybody? When you got to your office, who were you with? Who were you talking to? For how long? And they keep going to get it's not an interrogation, but they keep going in a skilled way to get the maximum information. If, for example, what I had said was that I came through on the train, they'd want to know, well, where was I sitting? They then want to go and look at what was going on in that train. Who was near me? Did I speak to anybody on the train? I came out at Waverley Station. Did I just walk straight through Waverley and come up the stairs, or did I go into a shop and buy anything? Was I in a queue waiting for a shop? We're some weeks ahead here, by the way, in terms of the restrictions that are lifted, but imagine it, and so on. and then they then go and look, because obviously if I was in a shop and I was in a queue and I was served, I wouldn't know everybody that was in that queue with me, and we may not be 2 meters apart. Depends how good the shop is at doing its job and how well I'm complying with what I'm doing. They may then go and look at other sources of information to help them identify that. But that is something that they need to determine, remembering that these are health protection teams led with that clinical input from health protection and well skilled and experienced in this exercise. So they lead all of that and they make those decisions, including whether or not they consider that they have identified a cluster or an outbreak, and what they then do in wider notification about that cluster or outbreak.
Thank you very much, Cabinet Secretary. And I have one final question, which is on sentinel surveillance, using testing as a way of establishing prevalence and incidence. Clearly, the basis in which some of that has been done may have changed over the last couple of months, but I wonder if you can tell us whether there are any outputs from sentinel surveillance as yet, and whether it has given us any better idea of incidence, of prevalence, or of the number of people who have been infected. Cabinet Secretary.
So there's the community enhanced surveillance is actually that figure that I gave you earlier, which tells us that with that 95% confidence interval, the most recent figure estimates that the range is between 2.9 and 7.5% of incidence in the community. Now, that's a very important figure. That was at the beginning of May. As we go through this month and get the other figures that come forward, but also as we go into June and as measures are eased in terms of the lockdown, then looking at that figure from the enhanced surveillance in the community, as well as what we also look at, which is, of course, the number of cases, the number of positive tests, the number of hospital admissions, and all that data begins to advise us as to whether or not the set of decisions that First Minister will announce tomorrow, what that has done to the prevalence of the virus in the community, and whether or not that then permits the next step at the next review period. So all of that information comes in from those different sources, and that informs our judgment. But as the First Minister has said, advice comes from all these sources, but politicians need to make the decisions and make the judgments on the basis of that advice.
Thank you very much, Cabinet Secretary, and thank you very much for your evidence this morning, which is much appreciated. There were one or two points, I think, on which we will no doubt follow up on that evidence, but certainly that's been really helpful, and can I thank Caroline Lamb also for taking part in the meeting. That concludes the public part of our meeting. Our next meeting will consider other aspects of the COVID crisis, and that will be next week. Information about that meeting will be in the business bulletin and in the committee's social media. I now adjourn this meeting for 5 minutes. We will resume on Teams at 11:40. Thank you very much.